Can you see my screen?
Yes.
You can see the presentation.
On my screen, I've got a black box kind of in the middle
Okay.
of
I
the.
also have that, yeah.
Okay. All right. Okay, Laura, are you there?
Yes, I'm here.
Okay, would you admit everybody, please? I
Sure.
cannot see if I put the screen up, I cannot see the people.
Okay, I'll take care of that.
Thank you, sweetie. So good morning, good afternoon, good evening, wherever you are. Thank you so much for joining us today in this new edition of the Maternal Health Supplies Caucus webinars. My name is Milka Dinev. I am the caucus backstop. And in this occasion, we will have the Maternal Health Supplies Caucus Chair, Dr. Metin Gulmesoglu, with us, who will be the moderator of the webinar. Please keep your microphones turned off to avoid the background noise of your offices or your homes. And we will leave the questions to the end of the presentations. We have a very interesting webinar today, and we will make available the recording as well as the presentations to you a couple days later. Do not hesitate to chat with Laura Mayer or with me in case you have any problems. And welcome again to the Reproductive Health Supplies Maternal Health Caucus webinar. The microphone is yours, Metin. Thank you.
Milka, and greetings to everyone. My name is Metin Gulmesoglu. I'm also the Executive Director of Concept Foundation. And I'm very pleased to be able to facilitate this discussion today. We have 60 minutes, 3 presentations, and we are hoping to have 10 to 15 minutes for Q&A. And we are going to discuss non-pneumatic anti-shock garment implementation experience in Zambia. Anti-shock garment work, I think, in my last 25 years of experience in global maternal health, is the most ignored, neglected, life-saving technology that I have come across. And I think it's important to put things in sort of balance as to where we can make a difference to maternal health and improving maternal health. And this is clearly one of the key interventions. So I won't talk too much because we have Sue Ellen Miller, who is the mother of NASG, I would say. But she has spent quite a few years on this technology and gone through very tough clinical trials, implemented clinical trials in this field. So, Sue Ellen, over to you. And then you have 10 minutes, and then we'll continue with our Zambian colleagues from CHAI from Zambia and Ministry of Health, and then we'll have a discussion. Thank you, and over to you.
Thank you. Hi, good morning, good afternoon, good evening to everyone. It's a pleasure to be here and to join this distinguished panel of people with so much experience and knowledge of the local context. So next slide, please. Okay, so this is what we'll be doing today, which Metin said already. And next slide. My talk today will be some background and update on the NASG, a brief description, the review of the NASG results at both the tertiary level and the primary healthcare level, the cost effectiveness, the location of positive responses and guidelines to the NASG, and then some thoughts for the future for conclusions. Next slide, please. So I think some of you know what the NASG is and what it looks like. For those of you who don't, it is a very simple neoprene and Velcro device that closes tightly around the lower part of a woman's body who is having severe obstetric hemorrhage and is in shock. Next. It works very simply, as most of us know, that when the body is in shock, the lower part of the body fills with blood, the brain, heart, and lungs are left without oxygen. And it's this very simple circumferential pressure which causes the blood to shift, the blood that's left in the body, and to decrease bleeding, but mostly to restore the perfusion to the heart, lung, and brains. Next. NASG is very unique. It's the only thing that does what it does. And you can use it with any hemorrhage therapies, with uterotonics, with vaginal procedures, with bimanual compression, with a balloon, with any other device or any other thing that's going, any other procedure. It's not a competition. It's not either or. This is a first aid device, buys time, especially for places where there is either a long transport from one facility to another, or in any facility that has an operating theater or blood or anesthesiologists or surgeons, but there's a delay in obtaining that level of care. It can be used with the patient who has uteronatony, the primary cause of obstetric hemorrhage, that doesn't respond to uterotonics. So we try first medical approaches, and then if that doesn't work, then we need to move on. And sometimes moving on means transport. It's also effective for all obstetric hemorrhage, any form of obstetric hemorrhage, which goes to complications of abortion, ectopics, uterine rupture, genital lacerations. And the only thing that's out there that reverses shock, if we're delayed waiting for a blood transfusion, you can use it. You can use something else if you really want to stop the bleeding, like perhaps a balloon tamponade or other method of turning off the tap. But if the woman has already gone into shock, we not only want to stop the bleeding, we need to reverse the shock. Next, please. Okay, so NASG has been proven to reduce maternal mortality. And I think this is a very important outcome. Very few devices or procedures in medicine can say that they reduce maternal mortality. You can look at any number of studies we've published on efficacy, and those will be on the website safemotherhood.ucsf.edu. We've conducted clinical trials in Nigeria, Mexico, India, Egypt, Zambia, and Zimbabwe. And a summary of those studies were published in a systematic review by a team from WHO. And among the observational studies that we conducted, the NASG reduced maternal mortality by around 50%, 48% in this case. We conducted an RCT in Zambia, in Lusaka and the Copperbelt, and in Zimbabwe to demonstrate if earlier application at the primary healthcare level made a difference for all women who were transported to a referral center and received the NASG at the referral center. So this was not a comparison between no NASG and an NASG. It was whether you apply it early or not. And we had too few incidents for statistical power, but we had a clinically significant and a very large 57% reduction in mortality. with no safety issues. Next slide, please. The NASG, and I remember working with Metin when he was at WHO, the safety is what's outstanding for something that works so effectively. There are many more uses than the 10,000 that we carefully documented, but in those 10,000, we had no reports of any safety issues and no side effects, minor or major. And these women were very ill, critically ill in some cases. They've gone into shock. And there was no increase in any of the side effects that might occur or any safety issues. Next. So starting in 2012, WHO added the NASG to their guidelines, and USAID published some highlights to every country to examine their national guidelines and ensure NASG, and to examine the training curricula to ensure providers are trained. And this was using both pre-service and in-service. So many other organizations and national policymakers have included the NASG in their national guidelines. And this is very important because the procedures in each country are different, registration is different. So getting to the country level is also quite important. Next. So we have, after the clinical trials, it became sort of unethical to ever do another kind of, not use of NASG and use of NASG. So we moved on to practical real-world experiences and documenting those experiences. Tanzania was a country that we worked in, and I'll go into a little bit of detail about that. In Kenya, we have the Lawality Community Alliance, some presentations at FIGO, but also a paper is forthcoming on their results. And in Niger, NASG was part of the peripartum strategy for primary healthcare. And then Zambia, the purpose of today's meeting, and the findings from there will be presented. Next. So Tanzania, just a little bit of information. This was in 280 facilities that went from the comprehensive down to dispensary level. Next. And the objectives were to see how often was the NASG needed, and if when it was needed, it was actually used by providers. And importantly, while we didn't look at maternal mortality rates, we looked at case fatality rates. And we predicted a 25% decline in CFRs over the baseline rate, which was 1.70. Next. And we were delighted with this outcome, which far exceeded our 25% reduction. As I said, the CFR at baseline was 1.70, but the CFR at end line of the project was 0.76. So this is a 60% reduced relative risk of CFR. Quite impressive. So what are our questions for real world implementation? We've done all of these trials. We've looked at some of these outcomes. So the policy that is developed needs to be informed by local context and local needs. We need to manage sending a woman in an NASG from a primary facility to the referral facility. What are the referral procedures? How is she received? These are all things that need to be worked out. Especially challenging may be how to manage the cleaning and return of the NASG to the primary facilities. What are the role of ambulances and emergency medical technicians or ambulance drivers in using NASG and also getting the NASG into rotation? We also want to be sure that ministries and professional organizations have some ownership of this, so this becomes incorporated very quickly. The role of NGOs also needs to be explored further. How do we conduct training when we have rotating staff in maternities? So you could train one day and the person you trained will be off to another facility. And another topic of great interest to me is the preclinical or the pre-service training. So getting the NASG into the curricula of the medical, nursing, and midwifery schools in order to be sure that it's incorporated into everyone's reaction. Okay, I guess I've been told to shut up. So thank you very much for your attention, and I'm really glad to answer any questions. Thanks.
Well, and thank you. And you were spot on time. Thank you very much for that. Let's move on to Anisette Kamanga, who is a program manager for CHAI in Zambia. And Anisette, you will be providing some of the answers to the bullet points that Swellen mentioned in her last slide as well. So the floor is yours. Thank you.
Thank you so much, Metin, and hello, everyone, and I hope I'm audible enough. Thanks for that introductory presentation, Professor Miller. So yeah, in Zambia, just like other countries in the sub-Sahara, obstetric hemorrhage continues to be the single largest cause of maternal mortality, with postpartum hemorrhage being the largest contributor. Next slide. In 2018, whilst working in collaboration with the Ministry of Health, CHAI launched a 4-year integrated sexual reproductive maternal and newborn health program in northern province of Zambia. And it was supported through a partnership between the Elmer Foundation and a large anonymous donor. Our program goal, which was highly ambitious at that time, was to reduce unplanned pregnancies, to reduce maternal and neonatal mortality by 40% and perinatal mortality by 20% across the program geography, using these 6 pillars that I've presented right now. Like Professor Miller mentioned, establishing a referral and transportation system was critical for coordinating the evaluation of the NASG study. Next slide. So we introduced the NASG study as part of the bigger integrated SRMNH program in 143 facilities of Northern Province, just to get a better understanding of its usage and the logistical operations within the settings of our local health facilities. So prior to the deployment, I think I lost my slides. Yeah. So prior to the deployment, training of the NASG application was done by the national trainers during the emergency obstetric and newborn care training. Next slide. Next slide. Thank you. So like Professor Miller mentioned, previous slide, please. All right. So as Professor Miller mentioned, so previous evidence on NASG usage in Zambia came from clinical studies in the peri-urban areas with a robust logistical and financial support. NASG was only available and used at the hospital level. So there was no evidence at that time which looked at introduction of NASG into the current standard of maternity care in a low middle income. An important opportunity to gain traction in the response to the high maternal mortality from the obstetric hemorrhage. So the primary aim of the study was to identify the critical adoption, implementation, and maintenance factors which were influencing the NASG uptake in the obstetric emergency response system in the public sector health facilities for Northern Province, Zambia. Next slide. We conducted an observational study throughout the 6-month period of implementation. The analysis and documentation was completed around April 2021. If you look below the table, it shows how many NASGs were distributed per facility type during our study. Next slide. So these were some of the study components we implemented as an integrated program to evaluate the usage of the NASGs within the local setting. Next slide. So our results were organized into the 5 dimensions of the REALM evaluation framework, which looks at reach, effectiveness, adoption, implementation, and maintenance. For those who are familiar, the REALM framework was originally created to help with the translation of innovative interventions into implementation. So as a result of that, we chose this case to evaluate the process of incorporating this new first aid tool into our regular obstetric emergency response procedures. Next slide. So just to present some of the key summary results, the acquired skills and knowledge in NASG application by the healthcare workers was well sustained in all facilities of Northern Province, even way after many months of reintroduction. We saw a significant increase in the usage at health post level for the first time, and the healthcare workers felt confident using the NASG and were glad about introducing this life-saving garment, which addressed the management of postpartum hemorrhage. And a good proportion of the facilities managed to update their documentation on NASG usage, and we did not see any challenge in the process of keeping NASGs at each of the facility in terms of exchanging and then also the washing and the entire process. Next slide. So just to give some of the key takeaway points. The NAS most commonly applied at the health center level, where the majority of the deliveries occur, especially in the rural areas. And then it was also feasible to scale the NASG in a local setting, especially in the rural health facilities, without much reliance on the external support. Next slide. So I just want to end my my presentation before I hand over to Paul about the great ambitious achievement we attained in the integrated SRMNH program. That despite the country facing the challenge of COVID by the end of 2021, and based on a robust maternal and neonatal health surveillance system which were established across Northern Province, we were able to observe significant mortality reductions, as you can see from the graphs. So the success of the NASG introduction in Northern Province has driven the MOH to actually pursue action towards scaling up of the introduction of the NASG nationwide. Thank you so much. I'll hand over to Paul.
Thank you, Aniset, and you finished your presentation much earlier than I anticipated, so we'll have a bit more time for questions and discussions. Thank you for that. So let's move on to Paul Boualia, and Paul is from the Ministry of Health, and he's an educator and implementer in the Northern Province, if I understand correctly. And Paul, over to you, and then we'll have a general discussion about the Zambia experience and NASG experience overall. Thank you.
All right, thank you so much. Yes, Paul is my name from MOH, Zambia, Northern Province to be particular. So the NASG was deployed in the country and Northern Province in particular at a point when we had so many number of dates and we were in dire need of solutions. So this is a point when, as you have seen from the previous presentations from Aniset, over 45% of the dates were attributed to postpartum hemorrhage, and usually women went into hemorrhagic shock before they died. So the NASG directory addressed this number one cause of death in women, especially from the northern part of Zambia. Next slide. So training of the users and mentors. So when this intervention came on board, the training of the users was done through various platforms. a good number was intensively trained during EMOC trainings that was rolled out with support from Clinton Health Access Initiative. And then the other trainings were incorporated in clinical generic mentorship trainings before the mentors were actually sent out in the field. Then we also trained a number of cadre we called community health assistants, and those were actually to be more like messengers as mothers were coming to make this gadget, life-saving gadget, more acceptable when they come to the facilities. So clinical mentorship is where now we trained the majority of users and oriented them through clinical mentorship on site as we were doing the mentorship on them. Next slide. Okay, so this garment came as a precious service to us, and we needed to ensure that we keep it as long as possible. And we needed to ensure that everyone knows how to use it and care for it. So for us to ensure that cleaning was done very properly, we needed to ensure that the cleaning process was not done with high concentration of bleach. And because we use chlorine from this end, we needed to ensure that every mentor, every person that was using them was using the right concentration for decontamination. So we mentored them on how to use them, making the 0.01 solution to ensure that the bleach doesn't damage actually the NASG that we were using. So even when we were cleaning them, we used plain water, and then we were drying them in the shade to ensure that we actually keep them elastic and the Velcro on this garment was actually intact for as long as we could. Then we also drilled the users in the clinical staff to ensure that they are folded well, because when a woman is bleeding, you agree with me that time is precious, and unfolding this garment was easier when it was well folded after use. So we conducted several drills during mentorship to ensure that every person who participated in the use of NASG was able to fold it very well so that it can be unfolded quickly in an event of an emergency. Next slide. So consideration for use of NASG during ambulances, transfer and exchange replacement of NASG across facilities. So because we needed to ensure that this life-saving garment was available at all times in the facilities, we deployed several measures and plans to ensure that the constant users and patients could find them at any time, at any point in the facilities. So each facility started by having having their garments labeled so that they could easily be tracked as they were moving from one facility to another during ferrying of the clients from lower levels of care to higher levels of care. So the ambulance team also carried a minimum of 2 garments as they were moving with the ambulance. So what used to happen was when the ambulance team reaches a facility where a woman is in shock and the NASG has already been applied, they could get what they were carrying in an ambulance and leave that pair with the facility on the ground. Then they pick up the patient with the NASG on. So as the ambulance team moves to a higher level of care, they will actually find a team that has already been oriented, and they will get a fresh pair from the higher level of care, the hospital, and give it to the ambulance nurses so that the number that is carried by the ambulance is maintained, as well as the number that remains at the facility is maintained. And once the clinical care team at the hospital is done, they were mentored well to ensure that cleaning, drying, and folding of this garment is well done. So they will just keep on what they've already processed and give it back to the ambulance team, usually coming from a distant facility, and pass it on. Okay, so this is one nurse that was mentored on site. He's an ambulance nurse from Kasama, Northern Province. So one particular afternoon, he called that there was a critical woman with BP unrecordable, and I was very nearby. So I rushed to ensure that, because they were using it for the first time, we mentor them on site so they could also see the benefit of this garment. So here is a testimony from one of the persons on the ground.
Just a second. Just a second. Okay.
Yeah, I'm Lakson Yasulu, an ambulance nurse from Kasama district. So some few months ago, we had a case of PPH at the police clinic, and we were called to go and pick the patient. Now, upon arrival there at the facility, we found that the patient was in shock. The BP was unrecordable, and then there was need to apply NASG. So I found that my colleagues did not know how to apply, even myself. We called our nursing officer from the district, who came, and then he taught us just right there. We applied NASG before transporting the patient to Kasama General Hospital. Then after applying NASG, we took the patient together with the nursing officer to Kasama General Hospital. We found colleagues there, doctors, nurses, who welcomed the patient, and we started resuscitating the patient together, not until the patient improved. Then that was after 1 hour to 2 hours doing the resuscitation at the Kasama General Hospital. That's when we now left the patient after the patient stabilized at Kasama General Hospital.
Okay, so we learned some lessons from the deployment of this life-saving garment, and some of them is that it is important to place the NASG at all levels of care in appropriate numbers, because usually we were losing clients from, especially those who were being transported from very far. Some of the facilities, actually, it used to take us more than 10 hours to evacuate them. 4 hours and a half going, 4 hours and a half coming back. And usually we needed to ensure that before they reach advanced care, they were stabilized as they were being transported. Then it is also very important to train and mentor newly deployed staff to ensure that application and transfer chain is not broken. So those that were on the ground when we deployed this garment, most of them were oriented, but we keep on recruiting staff, and this is where we also need to ensure that we go to ensure that every clinical staff is mentored, because this really made a difference, especially from those cases that came from very far. And then functional and timely referral system and communication within the network of care is critical to get a woman in NASG to definite care. So this is, as I mentioned, as long as everybody doesn't break the chain, we are able to save women, those critical, even if they are very far from far-flung facilities. Then treatment must be available at the end of the referral process to higher facilities. So to ensure that there is continuity of care, yes, the garment really helps but it helps up to a certain point when we transfer the patients, and we been advocating actually to ensure that even at the end of care, we have to save the lives of this patient. And this is actually what we saw contributing to the reduction of the deaths after this garment was actually deployed. So in conclusion, high impact interventions like this we saw being deployed, combined with functional referral and ambulance clinical mentorship in management of shock, helped to actually improve the maternal outcomes and can be sustained beyond partner support. So what we are doing to ensure sustainability is we actually, when it comes to the time of planning, we put them in our micro plans, in our what we call medium-term expenditure frameworks, so that when we have funds available, resources available, it's justifiable that we replace some of those that we've actually started losing in the process. Because it's been actually 6 years since we deployed them, and we need to replace them so that continuity of care and saving of mothers continue from this end. Thank you.
Thank you, Paul. This is such a great presentations. Thank you both. Thank you all for really taking us through this experience, which I think I didn't realize that it's been over so many years. There has been several questions in the chat, and maybe I'll try to direct them to the appropriate people if I can. One question was about the cleaning, of the devices, cleaning and reforming processes. And maybe, Aniset, you can respond to that. Suellen already put the cleaning guidance in terms of the mild bleach and the concentration and so on. But in terms of the actual use, what did this create a problem, or was it seamlessly applied?
Thanks, Metin. And I think also Paul did touch base on the way the NASG was being kept and the way it was being exchanged and the way it was being cleaned. I think following that, the guidelines that we had put in place, we didn't see any of those kind of challenges as Paul had alluded. And each time they would have a case, and then at the point where they're delivering, when it's going to maybe the higher level facility, they would do an exchange from that, so that the referral vehicle which took the pregnant woman to the facility, they would then come back with a clean one from that facility. So it worked well. We didn't see any kind of challenges, unless maybe if Paul had some bit more insight on this. Thanks.
Paul, do you have any comments on this?
I think we didn't have any challenge with that. In terms of care, cleaning, I think I saw where it's been touched. I think it's 0.01% concentration that we were using, actually, according to the guidelines, yes.
Thank you, Paul. And maybe I'll let you respond to the next question. There are a couple of questions about the logistics. I think people are wondering how you sort of maintain this moving of the device from the peripheral facility to the ambulance, to the healthcare, the referral facility and back. And I think there are questions about how practical or how it was working in real time. And also, could you maybe tell us how many times each device is usable after all this cleaning and drying and so on?
Okay, so for us, it was more like a cycle, because it was starting from the facility. The people who were leaving the freshly done or processed garments were ambulance nurses. So ambulance nurses were more like key because for them, they kept on, they were moving between two facilities, lower level facilities, then advanced care facilities. So ambulance nurses could get what was being used from the hospital after they've been cleaned and then take it to the facilities where originally they actually got the cases. So for us, this cycle worked very well. We did not hear anywhere where we said because of this process, the facility has actually completely run out of the garments, because even up to now, we still have the same numbers in the facilities because before one is released, another one is replaced. Thank you.
Can you give us any information on how many times? Anisette, please.
Yes, maybe just to add on what Paul said, and also referring to one of the questions in terms of like how many NASG, how did we establish or determine the number of NASG to put in the facility? I think we started with, first of all, looking at the data from the national HMIS to see the estimates of PPH and everything else. So we could tell, like, okay, from the calculations that we're seeing, we feel maybe 2 per health post should be able to manage for any eventualities of a case. And then at the higher level facility like the hospital, because we knew that the hospital was the place where they were referring to, and we knew that in case maybe 4 or 6 of those facilities tend to refer, then the hospital should be in a position where they can actually exchange without them running out of the garments. So yes, we definitely worked out with the numbers within the national HMIS just to come up with those. Thanks.
Thank you. There's one question from Robin Churchill about the policy environment, and I wanted to ask, before you started, was there a national policy recommendation about NASG use in the country? Was it included in essential lists, medicines or device lists, or did this happen organically while you were implementing? Or what is the policy situation right now with regard to NASG in Zambia?
Okay. I think Paul will chimp in, but what I remember about that time is that the study itself did accelerate the processes of coming up with a policy brief. And I know Rapson is on the call, is going to maybe chime in on the policy brief that we had actually developed and presented to the ministry. But in terms of commitment, I think we saw this huge commitment from the ministry. It's just that the time that all these things were happening also, that's the time when we had COVID. I still remember from the ministry that they had actually even set up a large procurement to get the NASG. Until when COVID came, they had to deviate those funds towards COVID. So I remember very well there was that commitment at that level. And the idea also with the study was to ensure that we come up with these recommendations at the lower settings, like what was possible, what was sustainable. Is this rotation going to be sustainable? Is it not sustainable? So that's the recommendation that we provided in the policy brief. I don't know if Paul and Rapson can chime in. Thanks.
Paul?
Okay,
yeah,
maybe
thanks, Anissa. On the policy, yes. So after the NASG was implemented in the sites that have been described here, I think the next thing that we wanted to sort of take was to disseminate the results and influence, policy uptake. And so we did a policy brief where we worked with different stakeholders, the OBS and GYN, as well as getting this evidence and packaging into, information that could be shared with policy makers. And in this case, we did engage different, both, within the Ministry of Health, but we also went beyond that to look at people that control resources, and these were parliamentarians. We also presented this evidence, and from, I think, the engagement, it was apparent that, they needed this garment to be scaled up. And so we saw deliberate effort by government to make sure that, this intervention was actually costed. So there is an investment case in Zambia. It's called the RAMCAN, Reproductive Maternal and Newborn Health Investment Case. And in that, it's actually costed. And they did include how, the country will be able to scale up these interventions across across all the provinces. So as we speak now, you will not just find the NASG into Northern Province, but the NASG is sort of, implemented across the country. And then with regards to being included to the essential medicine list, yes, it's a government that is basically recognized now in the country to be part of the government that should be used in terms of, addressing PPH. And right now, we're also trying to make sure that this is going to be part of the emotive trial that will be implemented in the country. Thank you.
Thank you, Rapson. And so if I understand correctly, at the point of implementation, when you started the project in Northern Province, there was no national policy recommendation or guideline document as such. But then as the experience accumulated and with the documents that you developed during the process, the government adopted, and now it's recommended within the country. Am I understanding it correctly, Rapson?
Yes, that's correct. So now the government is basically implemented across the country now. Yeah, so different partners are actually buying and utilizing it and supporting government, including government. We have seen them also prioritizing this government as well. So yeah.
Great.
Metin, may I ask a question because it might interest a lot of people? What is the cost in US dollars in Zambia of a garment?
Yeah, so I think the cost basically depend with the volumes. If the volume that is being purchased was quite significant, we saw it was reducing to as far as less than I think around $33 per garment. Yeah, that's what when we costed it out back then with the health economists, I think they did evaluate it around $33 per garment. Yeah.
Thank you. Well, $33, Suellen, is this generally the average, or is it higher, lower in other countries?
Well, it really depends on quantity, because part of the cost of getting it into the country is going to be shipping, and shipping a few is exorbitantly expensive, unfortunately. Now, there is a distribution in, I think South Africa is the location of the more local distributor, but still, there are special prices for lower income countries that can be negotiated through UNICEF and also directly with the manufacturer distributor. But I would say that that's for at least 100 garments, which would certainly be something one would want to start with. The $43 to $47 is probably accurate.
Okay. One other question I had, and thank you, Milka. I just saw that in Peru, Pathfinder International is introducing a locally manufactured NASG, so that's great. And Olu also put a price tag of X Factory, $43.55. One question I have is, what are the regulatory requirements? Can you just order it from outside the country and import it and start using it, or does it have to go through the national regulatory agency?
Are you asking me or someone from Zambia?
Asking it to everyone. Maybe Zambian colleagues or Suellen, if you have the information.
Yeah, my experience has been that it needs to go country by country, regulatory bodies on essential device list or some kind of list, WHO having a great deal to do with this, and UNICEF. So while individuals might just get one or several for a private use, to be used at the Ministry of Health level, it would need to generally go through the country regulatory level.
And Suellen, coming back to the challenge posted by Jeff Jacobs, what is the sort of current use level in LMICs and that you can refer to in terms of, I mean, it has been a long time since we know that NASG reduces maternal deaths. And it's one of these interventions that kind of annoys me that it is not being picked up and championed more commonly. What is the current situation? Are there any recent data in terms of purchasing and routine use?
Thanks for asking that question. I think it's really, really important. So thanks both to you, Metin, and to Jeff. The countries keep being added, more and more countries all the time. We don't have a registry exactly, but we do have manufacturers' information for how many garments have been ordered and this kind of thing. It is certainly gaining acceptance, but at a pitiful rate compared to what one would think would happen with this, dramatic lifesaver. So I think it's a need to get more recognition. I've been attending some meetings with Reproductive Health Supplies Network and find there's a lot going on with heat stable carbetocin, TXA, emphasis on that for underutilized, but not on something that exists with great evidence and now so many countrywide experiences. So it's a puzzle to me. One potential is that there is no pharma involved. There's no backing with big bucks from some pharmaceutical company. It's off patent, so it's very, it's not something that pharma is going to invest in. So I worry that that's one of the main problems, that no one is championing it, besides me and Chai and the other NGOs and WHO. We really need to have greater championship, and perhaps these results from Zambia will do some more convincing. I just saw today that PAHO added another country, Guyana, to their zero maternal mortality package. So that's happening a lot in Latin America. So any other ideas that people have for getting some more wide distribution, I'd be really interested to hear it.
Thank you, Suellen. Andrew put the information from Ethiopia as well.
Could I jump in here, Metin? Would you mind? So I can't look out Zoom now to raise my hand, otherwise I would have done that. I just wanted to add to that because I feel like in this is the key question that Jeff's asked. Why have we not seen the NASG be scaled up over the past more than a decade? Given this, given the evidence, given the WHO recommendations, given the clear need. And I think Suellen's spot on when she talks about lack of ownership, the lack of championing of this product, but also the fact that there hasn't been much in the way of actually catalytic work to scale this up. And Ethiopia is I think the prime example, because as I said in the chat, this represents the country where I think I'm pretty confident saying Ethiopia is the country in Africa which is using the NASG the most, which has seen the greatest level of scale up. And the reason for that really is actually because of Chai. We came in, we introduced the product, we procured, we did some catalytic procurement initially, but then we transferred it over. And a few years ago, the government of Ethiopia procured 5,000 NASG themselves using their own funds, which is nearly enough for one for every health facility, and have renewed that since. So more recently, have bought replacement NASG as well. Each one lasts about, I think it's 144 times, but obviously there's natural breakdown of the product over time. So there you are seeing the scale up. And then in Zambia, I think I predict that the same thing is going to happen as well. They're going through that process now. It's been adopted by the Ministry of Health, and they're going to procure more in the future using different sources of funds. Other countries are along those lines, but it's slow. Nigeria, obviously, is a vast country, but it's certain states are getting there. But there hasn't been, that catalytic force to introduce and push forward the NASG. And I think that's partly, as global stakeholders, it's down to us as well. There hasn't been enough championing of this. In the WHO, yes, they updated their guidelines or recommendations 10 years ago, but there hasn't been much more to push it forward in the years since. I think there's a lot more that we all could be doing as global partners and to support governments to introduce and scale this product up.
Thank you, Andrew.
Robin has worked out how to raise her hand. Okay,
and
thank you.
Robin is probably going to announce a mega funding initiative from USAID for NASG scale up. Please,
okay,
Robin.
now maybe I'm not going to talk at all. No, there's not a mega anything, but I do think that there's been reticence on the part of USAID. And full disclosure, I worked at CHAI while this was started, so I know the NASG work that CHAI has done from the inside as well. And then I came over to USAID. But what I do see here is there's the reticence among our missions is how do you build this system, this accountability system, sufficiently on a national scale. I think emotive was a really interesting study, and as I put in my notes, and you all, many of you know this better than I, the emotive trial protocol actually required governments to say they would not rotate staff out during the time of the trial. That is so critical. If you want local systems that are managed and there's accountability, you have to have the key staff who stay. Now, one of the things we are doing is we at USAID are really digging in on this and advocating to ministries, Dr. Boila, and to say that there's something about mandatory rotation that's undermining those critical key systems, both at the facility level and across the district. But once you get those in place, then you can do things like the NASG. You can have folks who know and have known and have 10 years of experience managing NASG systems that know how to replace it. Can ask, hey, has anyone seen that the used NASG get back to the original site? Things like that. Without it, it's a good idea. But I do think that we're coming to a place, particularly in PPH management, where we have to understand that it's the people in the proper places who aren't moving around all the time who are the foundation for these systems. And I think that as we advocate for that, then the system that is required to maintain usage of the NASG can be put in place. Thank you. There's no money.
I'm very disappointed. Thank you, Robin. I just want to reiterate this again. The stability of staff is so crucial. And I know it's going against decades of process. But in other organizations that I'm active in, like the International Childbirth Initiative, we also, from FIGO, we also are recommending maternity staff or specialized staff. You spend all this time training them. You do all of this in-service training over and over again, and then the people just rotate out. So the importance of that, and also, as I mentioned earlier, the importance of pre-service clinical training. If you're an ambulance driver or a medical student, all of those people, if they're trained when they're originally being trained in care, postpartum hemorrhage care or hemorrhage care, then those people are going to incorporate that in their emergency response, and it won't require as much repetitive treatment. And I think my last point is also about the emotive and the importance of having referral and transport, which is sort of the next step that needs to be taken in terms of packaging interventions that are going to enable women to stay alive during that referral and transport. Thank you.
Metin, can I just make a quick comment? I don't think it should be. I don't think pharmaceutical companies should be to blame here, right? We have to be careful because, and I say this based on experience within the pharmaceutical industry for a long time. If you don't include pharmaceutical companies from the beginning to support the clinical trials, they cannot. It is very difficult for them to buy into the studies because it may or may not meet regulatory standards, et cetera, et cetera. So we've had a number of occasions outside of maternal health, whether it be in HIV and other spaces, where groups have done very good work, like you're talking about here, Sue Ellen, that has not gone through the rigor that a pharmaceutical company would typically have to take it through, and they haven't been able to support it. So we just have to be really careful. It just goes back to the comments that people say. Integrating the private sector from the get-go to support global health challenges should be really should be a part of the calculus. It really should. And we see it with TXA, right? There's nobody that can put a TXA regulatory dossier together because it wasn't done through, using the pharmaceutical company rigor. Is this a similarity of why TXA is so slow to uptake? Is this the same thing for NASG? I don't know, but it's an interesting coincidence at a minimum. Over.
Thank Jeff, and I think we are not putting the blame on private sector as such, but the point is, I think it's a definite blind spot in the global maternal health effort. And thanks to all speakers, and Andrew, thanks for bringing the CHAI team to this platform as well. Much appreciated. Milka, any closing comments?
Thank you so much for attending this webinar. This is an attempt to put NASG out there, and as there are more developments and you have more results in other countries, let's use this platform to advocate for the use of the NASG. No, Latin America has been using it. Most of the Andean countries have been using it for a long time, and they are still using it. They have found some creative ways of producing a local version of the NASG, but it is something that we can use the caucus for. So thank you so much, and please keep in touch with us at the caucus. If you have any other ideas of webinars that we should be preparing in the near future, let us know. We're more than open to host your webinars. Thank you so much. Have a great weekend. Thank you, Metin, Sue Ellen, Dr. Paul Bualga, Anicet Kamanga. Thank you so much for your presentations today. It's been wonderful. Have a great weekend. All the best. Bye-bye.
Bye. Bye.
See you soon.
Bye.
Bye-bye.